Hi, this is lecture 1 of session 5 of the metabolism module. My name is Dr. Majid Hamid Al Aboud, and I will talk about diabetes mellitus. So, the subject of diabetes mellitus is very important, and in this lecture, we will cover 8 learning objectives. First of all, I will describe the meaning of diabetes mellitus by defining it. Then I will differentiate between the main two types of diabetes, that is type 1 and type 2. Then the typical pattern of presentation of each type of diabetes. And I will talk about the sequence of events that will lead to diabetic ketoacidosis, a very serious problem. And I will talk about the causes and the complications of chronic hyperglycemia as well as hypoglycemia. In learning objective 6, I will talk about the principles of management of diabetes, and then I will talk about the principle of monitoring of diabetes by glycosylation or glycated hemoglobin, which we call it HbA1c. And finally, I will talk about the common long-term side effects or complications of diabetes. Diabetes mellitus is defined as a group of metabolic disorders. So it is not a single metabolic disorder. In fact, it is a group of metabolic disorders that is characterized by chronic hyperglycemia. So it is a chronic process. And by hyperglycemia, we mean high blood glucose level. So it is a chronic hyperglycemia. This chronic hyperglycemia is due to either insulin deficiency, like in type 1 diabetes, insulin resistance, like in type 2 diabetes, or a combination of both insulin resistance and insulin deficiency. In general, we have many types of diabetes, but we can classify diabetes into type 1 or type 2. Type 2 diabetes is the most common type of diabetes. Around 90 to 95% of diabetes is type 2, while type 1 diabetes represents around 5 to 10% of all cases of diabetes. And to differentiate between the two, we have some characteristics. First of all, regarding the pathophysiology, type 1 diabetes is characterized by a state of insulin deficiency. There is destruction of the beta cells of the pancreas that are responsible for secretion of insulin. So the patient will have a state of no insulin. There is insulin deficiency. While in type 2 diabetes, there is insulin, but there is resistance to the action of insulin. So the body of patient with type 2 diabetes will resist the action of insulin, usually due to obesity and increased fat mass. Regarding diabetic ketoacidosis, DKA, it is common in type 1 diabetes, but it is very rare in type 2 diabetes. Regarding weight, usually people with type 1 diabetes are lean. They are thin. They are not overweight or obese. Unlike people with type 2 diabetes, usually they are obese because, as I said, obesity is the major cause of insulin resistance. What about the age? Usually people with type 1 diabetes are young, below the age of 40 or 30 years, while people with type 2 diabetes, they are older. They are above the age of 40 years. What about the onset of symptoms? So the onset of symptoms in type 1 diabetes usually sudden. Within weeks, the patient will have the symptoms of type 1 diabetes that we will talk about later on. While in type 2 diabetes is very gradual, and the patient might have type 2 diabetes for many, many years without knowing that until he, have, he has severe hyperglycemia. What about the fatality if left untreated? And by fatality, we mean death. So if a patient with type 1 diabetes is left without a treatment with insulin, usually he or she will die very soon, rapidly. While if a patient with type 2 diabetes is left without a treatment for many years, usually they will not die. So the onset or the fatality is slow. What about insulin therapy? Insulin is required immediately for people with type 1 diabetes because they don't have insulin, as we said. There is a state of insulin deficiency. While in type 2 diabetes, because the major pathophysiology is insulin resistance, so they have insulin, especially in the early stages of the disease. So insulin is not required immediately, but later on, we're gonna need insulin in the treatment. Now I will talk about the natural history of type 1 diabetes. So a patient with type 1 diabetes usually will have genetic predisposition. So there is certain genetic defect in them, usually in the HLA system, and usually in the DR3 and DR4. And then we should have a trigger. So in addition to the genetic predisposition, there should be a trigger. What sort of trigger? So either a viral infection like influenza or mumps or whatever, pancreatitis, viral pancreatitis or gastroenteritis, or sometimes it might be a stressful situation, an intense stress like emotional stress or physical stress. For example, a extreme happiness or extreme sadness or fear might be a trigger. So this trigger, in addition to the genetic predisposition, will result in immune activation. The immune activation means that there will be activation of the immune system to produce autoantibodies. And by the autoantibodies, we mean antibodies from the same own body toward the same body. So there will be autoimmune activation, especially the GAD antibodies, and we have the anti-insulin antibodies, anti-islet cells antibodies, different types of antibodies, and as well as activation of different types of cells like macrophages and natural killer cells and lymphocytes. These autoantibodies and cells will attack the beta cells of the pancreas that are responsible for secretion of insulin and will destroy these beta cells, resulting in their destruction, and therefore there will be no more insulin and there will be state of insulin deficiency, and at the end it will result in the frank type 1 diabetes mellitus. So if we have a look on this graph, in the x-axis below you have the time. Usually it is not long time, as I said, it is a short time, usually weeks. And here on the y-axis we have the beta cells of the pancreas. So at the beginning there is good number of beta cells, but the patient has got genetic predisposition, that is the HLA, DR3, DR4. And then due to a stressful situation or viral infection, which we call it the trigger, there will be immune activation and formation of autoantibodies that will start to destruct the beta cells of the pancreas. As a result of that, the number of beta cells will be decreased. But so far till now, there is no features of diabetes because half of the pancreas is still there, half of the beta cells of the pancreas actually. And then the patient will have, after a few weeks, the metabolic abnormalities with the reduction, further reduction in the number of beta cells of the pancreas. There will be metabolic abnormalities. And finally, when the number of beta cells is very low to produce insulin, there will be a state of insulin deficiency at this point. And there will be clinical diabetes. And the patient will have the symptoms of diabetes, the classical triad that I will talk about later on. So to summarize it again, the pathophysiology of type 1 diabetes is so simple. There is genetic predisposition plus environmental trigger, whether viral or stressful situation. This will stimulate the immune system. There will be immune activation with the result in beta cells destruction. While the natural history of type 2 diabetes is totally different. So here in the x-axis we have the time, which is usually in years, not in months, like in type 1 diabetes, as you can see. In the y-axis we have the beta cell function again. So at the beginning there is 100% beta cell function, and the patient does not have diabetes. But with the time, because of insulin resistance, and there is a gradual beta cell failure or destruction, there will be decline in the beta cells. And here IGT is called impaired glucose tolerance, which means when we give a patient a load of oral glucose, say 75 grams of pure glucose, the response of his body will be abnormal. And he will have higher blood sugar than healthy people. Look at the years. This happens usually many years before the time of diagnosis, which is this one, the 0 year. So around 10 years before the time of diagnosis, the process is usually or already started. And then with the progressive decline in the beta cell function, which is a very slow process over many years, there will be postprandial hyperglycemia. And by the term postprandial, we mean after the meal. So the patient will have high blood sugar after eating meals, while if he is fasting, the sugar is normal. Until the number of beta cells decline to around 50%, the function of the beta cells, the patient will start to have the symptoms of diabetes. And then we here at this time, we usually start with a tablet or oral treatment. But with further decline with the years, usually after 10 years from the time of diagnosis, then the patient will be converted to a state just like type 1 diabetes, a state of insulin deficiency. And at this point, the patient usually will need insulin as a treatment. So what is the typical pattern of presentation of type 1 diabetes? So as we said, usually the patient is young, thin or lean, with a history of recent viral infection or a stressful situation, plus triad. Triad means three things, three important things. Number one, polyuria. So the patient will come to you complaining of polyuria. And by polyuria, we mean passing a large amount of urine. Why is that? Why the patient with type 1 diabetes will have polyuria? This is because the kidney in normal individual and healthy individual will filter small amount of glucose, and then this small amount of glucose will be reabsorbed by the kidneys. So there is no glucose in urine, but whenever there is large amount of glucose in the blood, there will be large amount of glucose filtered through the kidney, and the glucose will go out and with the urine. And because the glucose is osmotically active material, with each molecule of glucose, we will have one molecule of water. So there will be large amount of water. And that is the pathophysiology of polyuria in diabetes. The second symptom is thirst or polydipsia. Thirst or polydipsia, because the patient is passing large amount of water in the urine because of polyuria, there will be state of dehydration. And this dehydration will stimulate the osmotic center in the brain and will stimulate the thirst. So the patient will drink a lot of water, many liters of water per day. The third characteristic feature is weight loss. And why weight loss? Because there is no insulin in the body, so glucose is not uptake by the cells. There is no uptake of glucose by the cells. As a result of that, the body needs energy. It will depend on fat and protein in the muscles and the adipose tissue. So there will be breakdown of these fat and glycogen in the muscle. As a result of that, there will be weight loss. So please remember the three P's whenever you talk about symptoms of diabetes: polyuria, polydipsia, and polyphagia. We know now what is polyuria and polydipsia. Polyphagia is excessive eating. So patient with type 1 diabetes usually eats a lot of food, large quantities of food, but they will get weight loss. They feel hunger because of insulin deficiency and failure of uptake of glucose by the cells. This is a beautiful graph describing the mechanism of polyuria. So a normal glucose handling in a healthy individual, there is only few amount of glucose, little amount of glucose filtered through the kidney, and 100% of this glucose will be reabsorbed by the proximal tubule of the nephron. While therefore there is no glucose in urine. But in a patient with diabetes mellitus, there is high blood sugar, hyperglycemia, large quantity of glucose is filtered in the kidney, which is above the ability of the kidney to reabsorb. It is above the reabsorption capacity of the kidneys, so there will be leaking of glucose in the urine. With each molecule of glucose, there is a molecule of water, and as a result of that, there will be polyuria. While the typical pattern of presentation of type 2 diabetes is a bit different because it is a gradual onset usually. There is no state of insulin deficiency at the beginning. But sometimes people with type 2 diabetes may present with the characteristic 3 Ps that we talked about in type 1 diabetes. However, the usual presentation of people with type 2 diabetes include lack of energy, so they feel tired all the time, persistent infection, especially genital tract infection with fungi, we call it genital thrush. Why is that? Because glucose is secreted in the urine, and this represents a good medium for bacteria to grow and fungi as well. Similarly, they will have feet infection of their feet, and there is characteristic slow wound healing because there is defect in the immune system, and there is a good medium for bacterial growth, as I said. So there will be slow wound healing. The wound of people with type 2 diabetes is very hard to heal. And sometimes the patient may present with visual problems due to osmotic effect on the cornea and the lenses. How do we diagnose diabetes? So we should have symptoms of type 2 or type 1 diabetes that we talked about plus one of the following. First, a random blood glucose. By random, we mean blood glucose that is taken at any time. Blood sample taken at any time of the day. We call it random blood glucose of 11.1 millimole per liter, or a fasting that is without eating in the early morning, a fasting usually of 8 hours fast, blood glucose of 7 millimole per liter, or by doing what is called the OGTT. And by OGTT we mean oral glucose tolerance test. Here we give 75 gram of glucose dissolved in water, in a bottle of water, to the patient, and we measure blood glucose 2 hours after that. If it is above 11.1 millimole per liter, this is diagnostic of diabetes. But these are if there is symptoms. But what about if there is no symptoms? The patient is totally asymptomatic. There is no symptoms. Doesn't complain of anything. We need to have two tests. We shouldn't depend on one test. We need to repeat the test. So we have either of any combination of these, but should be repeated on another day. Now I will talk about a very important complication that is diabetic ketoacidosis, and we abbreviate it as DKA, usually a very common term that you're gonna see in the emergency room a lot. So because there is no insulin in type 1 diabetes, there is insulin deficiency or lack of insulin, there is no glucose uptake by the adipose tissue and the muscles usually. As a result of that, the liver will start to do what is called beta oxidation of fat in order to produce energy. This increase in beta oxidation of fat will produce ketone bodies, and we have three of them: acetone, acetoacetic acid, and beta hydroxybutyric acid. Acetone is volatile, which means it can go out with the breath, and it will have a very characteristic smell, and most of you have smelled acetone. And once you smell it, you will know that there is a patient with DKA in the emergency room. So these ketone bodies, when they are produced in large quantities, they will be accompanied by hydrogen ion production. And therefore, we will end up with a state of acidosis with ketosis. We call it diabetic ketoacidosis. Now let's talk about hyperglycemia. So whether we have insulin resistance or insulin deficiency, there is no source of energy because there is no uptake of glucose by the muscles and the fat. As a result of that, the liver will have gluconeogenesis, or production of new glucose molecules in order to replace this state of insulin deficiency. And this actually will increase the hyperglycemia in the patient. Insulin resistance or deficiency, and because of low uptake and storage by the muscles, will result in more hyperglycemia because the glucose will not enter the muscle, it will stay in the blood. This hyperglycemia will result in polyuria, more urine, and polyuria will result in dehydration, and dehydration will make the patient feel thirsty. In addition, dehydration will result in low renal perfusion, which means little blood is reaching the kidneys. On the other hand, hyperglycemia will result in lipolysis because, as we said, we need a source of energy. There will be breakdown of fat and the patient will have weight loss. This process of lipolysis will produce more ketone bodies and more acidosis. And acidosis will stimulate vomiting. That is why a patient with diabetic ketoacidosis usually present with vomiting. And vomiting will make dehydration even worse. So it is a circle. And dehydration will affect the kidneys, and acidosis will result in insulin resistance. And then insulin will result in hyperglycemia, this resistance. What about hypoglycemia? So hypoglycemia usually will not occur in a patient with diabetes unless there is one of four things. Either the patient is on insulin and he took high dose of insulin without eating, and as you know, insulin will cause hypoglycemia, or the patient took high dose of oral anti-diabetic that can cause hypoglycemia, or there is renal impairment because in kidney failure or impairment of the kidney function, the insulin will stay in the blood for a longer period of time, and there is impairment of the liver function because you know liver is responsible for gluconeogenesis. So if there is no gluconeogenesis, there will be hypoglycemia. Hypoglycemia is a very dangerous situation because the brain depends on glucose as the only source of energy. And if there is no glucose or low glucose in the brain, the patient will have symptoms of low glucose in the brain, which is confusion and sometimes even coma. And we call this neuroglycopenia, low glucose in the brain. How do we manage type 2 diabetes? So there are three main steps or pillars in the management of type 2 or type 1 diabetes. First of all is the diet. Second one is the exercise. And diet and exercise, we call them together lifestyle changes. And then we have the medications. And we have either oral tablets or injectable like insulin. Let's start with the diet. This is an example of a healthy plate for a patient with type 2 diabetes or type 1. So usually we ask them to divide their plate into the following. Half of the plate in the form of vegetables, 1/4 of the plate in the form of carbohydrate like rice or bread, and 1/4 or 1/4 of the plate in the form of protein like meat or eggs, and a cup of water, and probably a piece of fruit. But remember, when you treat a patient with type 2 diabetes, remember he has another comorbidities. And by comorbidities, we mean another conditions associated with diabetes. Usually he will have hypertension, so we need to treat his high blood pressure. If he is a smoker, he should quit smoking or stop smoking. If he has sedentary lifestyle, he should do physical activity. If he is overweight or obese, we should try to lose his body weight to help him losing body weight. And of course, to avoid high fat and cholesterol level, because people with type 2 diabetes, usually they have high lipid in the blood, hyperlipidemia. Now I will talk about the concept of HbA1c or glycated hemoglobin. So glucose, if present in the plasma in high concentration, it will react with the terminal valine of the hemoglobin molecule to produce the glycosylated hemoglobin, which we call it HbA1c. Therefore, HbA1c or glycated hemoglobin is related to the average blood glucose concentration over the preceding 2 to 3 months. Why is that? Because the half-life of the RBC is usually 2 to 3 months. So if we measure the glycated hemoglobin, we will measure the amount of glucose that is attached to the valine molecule of the hemoglobin, valine terminal of the hemoglobin molecule. It will reflect, it will give us an idea about the average of blood glucose over the past 2 to 3 months. A normal value of hemoglobin A1C is 4 to 6%. And usually we send people with type 2 diabetes for hemoglobin A1C and check it every 3 months. If it is above 10, of course this is very high. And I would like to talk to you about a very important study called the UKPDS. You will hear about it very frequently. So in this study that was conducted in the United Kingdom, they found a 1% reduction or decrease in HbA1c is associated with a large reduction in the complications of diabetes. Just 1% reduction will result in 37% reduction in microvascular complications such as kidney disease and blindness, and diabetes is the major cause of renal failure and blindness in the world. It will reduce the rate of amputation due to peripheral vascular disease, and diabetes is the most common cause of amputation worldwide. It will reduce the rate of death due to diabetes by 20%. It will reduce the rate of heart attack like myocardial infarction and ischemic heart disease. And finally, it will reduce the rate of stroke or cerebrovascular accident. So what are the long-term complications of diabetes? Chronic hyperglycemia will make glucose precipitated in the tissues, and it will have its toxic effect through the sorbitol and other metabolites like nitric oxide, and there will be depletion of the NADPH, and many complications will result. In general, we divide these complications into microvascular, which means complications due to disease of the large blood vessels, and this includes stroke or cerebrovascular accident of the brain, myocardial infarction in the heart, peripheral vascular disease with amputation, and we have microvascular, which is small blood vessels disease. And the microvascular include neuropathy, which is a defect in the nerves of the periphery, so the patient will have severe pain, tingling sensation, burning sensation in the feet and the hands. We call it stocks and the gloves, stockings and the gloves. Also, they will have retinopathy, problem with the retina, either exudate or hemorrhage, damage to the retina, sometimes even blindness. And we have nephropathy, which is defect in the nephron of the kidneys, and the patient at the end will have renal failure, but at the beginning they might have a leak of albumin in the urine. We call it albuminuria. In the beginning, it is very small amount of albumin in urine. We call it microalbuminuria. With the time, it will progress into chronic kidney disease, diabetic nephropathy, and renal failure, and the patient needs renal transplantation. So we should transplant the kidney from another person. Finally, of the microvascular complication is the diabetic foot. So this figure of the human body shows the different types of complication like cerebrovascular disease, retinopathy, coronary heart disease, nephropathies of the kidneys, peripheral vascular disease and amputation of the legs, neuropathy of the nerves, finally ulceration and amputation or what is called diabetic foot. Here is the picture of a comparison between a healthy individual on your left hand side. This is how we see pictures, but look at the right. This is how a patient with diabetic retinopathy see the picture. It's very miserable. And this is the diabetic foot with characteristic big diabetic foot ulcer. This is due to many complications like neuropathy, so the patient cannot feel his feet. Sometimes it might burn his feet or stand on his feet for a long time with a pressure ulcer. In addition, he will have a state of peripheral vascular disease, so no blood is coming to this area. There will be dead tissue. In addition, this is represent a good media with the dead tissue to the bacteria, and there will be secondary bacterial infection, and it might end up with amputation and deformity of the feet, as you can see. And thank you.